Hello, and welcome to the Alabama Public Health Training Network. Thank you for joining us today for our program, the Affordable Care Act Overview. If you have a question about anything being discussed today, please call or email during our broadcast. The phone number and email address are on your screen now and will appear again later in the program. Also, the sign-in sheet and evaluation are available online. You will need to register for this program in order to access those materials. Continuing education credits have been approved for nurses and social workers for today's program. In order to receive credit for this training, you must watch the entire program, then complete and return the sign-in sheet and evaluation. While content may continue to be relevant, CE credit will only be awarded for 1 year for nurses, expiring on January 31st, 2017, and 2 years for social workers, expiring on January 31st, 2018. I'm Kathy Caldwell, Director of the Bureau of Children's Health Insurance at ADPH, and I would like to welcome our faculty presenter today, Leonard Jack Nelson. He is an adjunct professor for the Department of Healthcare Organization and Policy and a senior scholar at the Lister Hill Center for Health Policy at the University of Alabama at Birmingham School of Public Health. Welcome.
Thank you, Kathy. It's a pleasure to be with you today, and I hope you will ask a lot of questions. I think you'll see I've been studying the Affordable Care Act for about 5 years. And the more I study it, the more elaborate or more complex it seems to be. It's like peeling an onion back. You just get different layers of complexity. And I've got, see if I can get my slides to work here. There we go. That's my name. I go by Jack, right? But my real name is Leonard. Here's a little diagram, and I usually put that up. That's I guess you'd say it's an organizational chart for our healthcare system post-Affordable Care Act. And people are kind of like stunned at how complex it is. But it's not really. The complexity was already there, right? What the Affordable Care Act did is it didn't totally transform our system. Certainly there were significant modifications, and the federal government took on more regulatory authority. But we already had a very complicated system in the United States. Probably, I would guess, the most complex healthcare system, if you can even call it a system. It wasn't designed according to any rational plan. It just grew over time, and obviously people with different political philosophies had a role in passing different legislation, and it's just kind of accumulated over the years. And the act itself, the Affordable Care Act itself, was about 1,900 pages. And of course, there's been already thousands of pages of regulation. But that's the way we do things in our country. Now, if you contrast it with Canada, the Canada Health Act is 9 pages long, okay? They kind of have a streamlined, simple system in Canada. We don't have that. Our system is the product of political compromises and differing ideologies from time to time. So it's a mixed private and public system. It is very complicated. The Affordable Care Act was passed in March 2010. And it was, at the time, it was a straight party line vote. No Republicans voted for the Affordable Care Act. President Obama had, of course, with his election, the Democrats had significant majorities in both the House and Senate. They also used, to avoid the filibuster problem, they also used something called reconciliation procedure. So they didn't, the Republicans did not have the opportunity to filibuster to defeat the bill. So this is the way we started out. And I think one thing we learned is that there is considerable polarization, ideological polarization on health care reform. But the odd part of this for me is this legislation, the Affordable Care Act, sometimes called Obamacare. You remember during the debate with Romney and President Obama, Romney called it Obamacare and he asked the president if that was okay, and he said, sure, I like that name. Okay, so So either one, you can use either one, Affordable Care Act, Obamacare. But it's based on Romney Care, right? That's where it comes from. If you look at the guts of the Affordable Care Act, it's Romney Care. It's legislation that was passed when Mitt Romney was governor in Massachusetts. And it was passed with bipartisan support in Massachusetts. The Democrats controlled the legislature there, but you had a Republican governor, and the Republicans generally supported it. And here's the really bizarre fact that you may not be aware of. Most of the central concepts in Romney Care were developed by the Heritage Foundation in the early 90s as an alternative to the Clinton health care plan. So just to make it clear for you, what the Affordable Care Act is, basically it's the Republican health plan that was passed under a Democrat president with no Republican votes, and still is the subject in many red states, obviously, of a good deal of opposition and hostility. So what a topsy-turvy world our political system is. Now, full implementation occurred January 1st, 2014. There were some other things that came into effect earlier. One of the earliest to go into effect was extending coverage to children of people who had employer-sponsored health insurance, which provided that they could stay on the plans until they're 26. And there's a lot of people who have gotten coverage through that, just through that measure. But the big features that we'll be talking about, the marketplace exchanges and Medicaid expansion and the major insurance reforms were not implemented until January 2014. Now, you may recall there were some problems with implementation initially with the exchanges, more with the federal exchanges actually than the state-based exchanges. And most of those glitches have now been worked out. Okay, so those were some temporary things that I guess the computers weren't right up to it at that point, but most of those glitches have been overcome and worked out. Okay, so I'm going to talk about the basic elements of the Affordable Care Act. And so I'm going to talk about what's called the three-legged stool. Three-legged stool, as you know, a three-legged stool, if you take out one of the legs, what happens? The stool collapses, right? So you've got to have all three legs to make it work. So we're going to talk about the three-legged stool that is at the heart of the Affordable Care Act. And these are insurance reforms, that's one leg. Subsidies is the second leg. And the third leg is what's referred to as individual mandate. We'll also talk about marketplace exchanges, which are a place that people in the individual and small group markets can go to purchase insurance. Okay? There are other places to purchase insurance, okay? But if you don't purchase insurance on the exchange, you don't get the subsidies. Okay? So you can call Blue Cross and say, I want to buy a policy without going through the exchange, but you won't get a subsidy. You can get the same policy, but you won't get a subsidy. So it's important to keep that in mind. We'll also talk a bit about the impact on large employers. And I characterize the legislation there as pay or play. If large employers don't provide coverage, employers with more than 50 workers don't provide coverage, then they may have to pay some fines. And we'll also talk about Medicaid expansion, which has been contentious. And Alabama is one of those states, along with several other red states, that did not expand Medicaid. Okay, three-legged stool. Again, insurance market reforms, individual mandate, premium and cost-sharing subsidies. Now, again, when we're talking about insurance market reforms, it's important to keep in mind, we're talking about the private insurance market in the United States. Okay? We have government programs like Medicare and Medicaid, but when we're talking about insurance market reforms here, with respect to the Affordable Care Act, we're talking about the private health insurance market in the United States. And we're talking really about three market segments. There's the individual market. That is, some person goes out to purchase insurance to cover that person and perhaps the family of that person. Okay? They're not part of a group. Then we have another market segment that we'll call small group. These are small employers. And then we have the large group market, which are sometimes very big employers, right? But anything over 100 would be generally considered large group. Now, we know, and we may mention this some more later, that many large employers don't buy insurance. They are self-insured. In fact, there's some pretty strong incentives for employers to self-insure. There's some legislation called the Employee Retirement Income Security Act that was passed in 1974. And this legislation preempts state laws relating to employee benefits. It also, however, has a savings clause that allows states to continue to regulate health insurance, because after all, states were, for a long time, the primary, and still are in many ways, the primary regulatory regime that governs private insurance. Okay? But there's another further thing, and I think we'll mention this outset, and if you are confused about it, just ask me a question. But there's also something called the Deemer Clause. So that says that self-insurance isn't insurance. So why is this important? Well, what it means is, as you may be aware, a number of states have certain mandated benefits. So if you write a health insurance policy in most states, you have to include coverage for certain services, maybe podiatric services, chiropractic services, mental health services, all sorts of things have to be in the insurance. But if a company self-insures, it's not subject to those mandates. Okay, so there's a strong incentive under the 1974 legislation, the Employee Retirement Income Security Act, for large companies to self-insure. And most all have. The companies any size now are self-insured. What they usually do is they self-insure, and that means they pay the losses. They cover the medical costs of their employees, but they'll hire an insurance company like Blue Cross to administer the plan, and they also have access then to the Blue Cross network of physicians. So that's the most common scenario for large groups, for large employers. Now, some of the reforms in this legislation do apply to all three segments of the private insurance market. It would apply to individual plans, purchased both on and off the exchange. It would apply to small group plans, purchased on and off the exchange. And it would apply to large group plans. Now, at the current time, you cannot purchase large group plans on the health insurance exchanges. That may change, but right now you can't do it. Now, some reforms apply only to plans that are offered in the individual and small group markets, okay? Particularly essential health benefits. Any plan sold on the marketplace exchange in the individual and small group market has to have certain essential benefits. There's 10 of them listed. I think I get to them later in the slides. But large employers don't have to have that. They don't have that requirement at this time does not apply to large employers, to large group market. Only applies to small group and the individual market. So that's one example. In the group market, some reforms do not apply to self-insured plans. Okay, remember I told you most large employers are self-insured. So many of these reforms, some of these reforms anyway, do not apply to self-insured plans. And there is a trend among smaller employers to also self-insure. So many smaller employers are starting to move toward self-insurance. They self-insure and then they buy what's called stop-loss coverage. in case they have a bad year. A lot of sick employees, you buy small stop-loss coverage to cover that. Okay. So that's one thing we're seeing is a greater shift to self-insured plans. And I think that's probably kind of an unintended side effect of the legislation. And again, the reason to go self-insured is you're not subject to the same regulations. And we'll talk about that, some other, in more detail about that later. There's also a provision in there that some of the reforms, in fact, most of the reforms, do not apply to plans with grandfathered status. That means plans that were already in place when the legislation was passed. And remember, the President said, we're not going to take away your plan. Well, to some extent, that's true. If you have a grandfathered plan and there's been no significant changes to it, if it was in place at the time of the legislation and there are no significant changes, you can keep that plan. However, there are many insurance companies in the United States that decided not to continue offering those plans. Okay, so it wasn't the legislation that said you couldn't offer it, it was the decision by the insurance companies. So grandfathered status, you can still go with what you had before if the insurance company wants to sell you that plan. They don't have to sell it to you. Okay, so let's talk about insurance reforms. And health insurance in the United States is it's got a very peculiar history, right? So if we're talking about private health insurance, we didn't really have private health insurance in the United States till the 1930s. Up to that time, we had some industrial sickness funds that would provide kind of indemnity coverage if you got sick. They pay a certain amount a day, just kind of like Aflac does. Okay, those were around. But up until the 1930s, private insurance companies didn't really think health was an insurable risk. Okay, it was just too uncertain. And what happened in the 30s was during the Depression, the census was down on hospitals because people didn't have any money. And so a group of hospitals, initially a hospital in Texas and a group of hospitals in Sacramento, they got together and they put together a service benefit plan. So you'd pay a premium, and in exchange for that premium, you would get, say, 21 days in the hospital. That was the beginning of Blue Cross. It was a nonprofit. It was a service benefit. And they used community rating. Okay, Blue Cross early on used community rating. Blue Shield is the physician side of it, right? The physicians said, well, this seems to be working pretty good, and we want our patients to be able to pay too, so we're going to put together an insurance plan. So that was Blue Shield. So that's the beginning of health insurance in the United States. But the key for Blue Cross is it had generally the support of the medical profession and the hospitals. In fact, it was run by the doctors in the hospitals. And community rating was used by Blue Cross. Now, what's community rating? Community rating means everybody who buys insurance pays the same rate. Okay, that's the way it was originally. They didn't do medical underwriting. They didn't charge you more if you were sick. They didn't charge you more if you were older. That was the way community rating worked. So that's kind of the beginnings in the insurance industry. Now, later on, there were a lot of changes, right? Blue Cross stopped community rating and did some things that to compete with commercial insurers that were going to employers and saying, you're paying too much for your Blue Cross insurance with this community rating. We can experience rate and get your costs down. Okay. So what does this legislation do? Again, this is addressing the individual and the small group market. One thing it does is it provides for guaranteed issuance and renewal. And now there was some legislation, maybe at the state level, that had some impact on this before, but this is fairly significant. In other words, if you buy insurance during the enrollment period, the open enrollment period that is an annual period, still going on here till the end of January. It started in, I think, October, and it's still going on till the end of January. The insurance company can't turn you down. Okay? and if they can't cancel you if you get sick. I mean, once you have insurance, they have to issue it. Of course, you've got to pay your premiums, right? You don't pay your premiums and get canceled, but as long as you pay your premiums, they can't cancel you, and they can't refuse to renew you if you get sick. So that's most people like that. They think, well, that's what we ought to be doing. People need insurance when they're sick, right? That's when they need it. The other thing that used to be the case with private insurance, of course, is sometimes they would say we don't cover pre-existing conditions. Sometimes they just would refuse to cover you at all if they thought you were too sick. Other times they'll say, well, okay, we'll issue a policy. Let's say somebody has asthma. Well, we won't cover your asthma. Okay? So that was a significant factor for many people. This legislation says, no, when you sell the insurance, you've got to cover pre-existing conditions. You can't refuse to cover those conditions. The other thing legislation does is there are now no caps. Policies used to have annual caps and lifetime caps. Maybe, you had somebody who was really sick with cancer, even though the cap was $1 million, you could bump up against the cap. So now there's no caps, lifetime or annual. And then adjusted community rating. Remember, I was talking to you about Blue Cross, how they use community rating and then abandon it because of competition from commercial insurers who are offering cheaper policies for healthy people. They were using experience rating and doing some medical underwriting. Okay, well, now medical underwriting is out. You can't charge a different rate if you're talking about an exchange policy. You cannot charge a different rate because of somebody's medical or health condition. That's not a factor that can be used anymore. You can charge a bit more for people that are older, but that is limited. You can only charge 3 times as much for an old person as for a young person. And the standard in the industry used to be 5 times. Okay, so that's a big change, adjusted community rating. Well, all that sounds quite good, doesn't it? To get these insurance reforms, make sure you have coverage, but there is a bit of a problem here. And we'll talk about that in a minute. The other thing in these policies, as I mentioned before, they have to cover certain essential health benefits. And there's a list. To some extent, the states have had a chance to develop their own standards, as long as there has to be tied to the most popular plan, for example, in Alabama, the most popular Blue Cross plan. But it's pretty comprehensive coverage. So if you buy a policy on the exchange, you get kind of what was the standard Blue Cross plan. That's what you're going to end up with. Outpatient care, trips to emergency room, hospital treatment, inpatient care, maternity, newborn, mental health, prescription drugs, and rehabilitative services. Okay, so you've got a pretty comprehensive coverage. It includes laboratory services, preventive services, which we'll talk a little bit more about in a minute. Of course, pediatric services include, and that would include dental and vision care for pediatric patients. Now, preventive services are also covered. And all non-grandfathered private health plans, including self-insured plans, all plans, have to provide coverage for preventive services that would include certain screenings and immunizations without cost sharing. Okay, no cost sharing, no copay, no deductible, no coinsurance, full coverage. And all plans have to do this, unless they're grandfathered. If they're non-grandfathered plan going forward, you have to cover preventive services without cost sharing. So this is a significant innovation or reform also. And of course, the justification for this is that will keep people healthier. The idea is when we get people access to preventive care, maybe that will actually reduce costs in the future. We don't know whether that will work or not. And there's a good deal of debate about that in the academic literature, but that was the justification for this. And there's a list that's taken from the United States Preventive Task Force on Preventive Services that is basically what's included in these preventive services. These are evidence-based, so the idea is we'll cover preventive services if they're on this list, and we've got these expert medical and scientific bodies have made recommendations of coverage because there's some evidentiary basis that they're effective and worthwhile. There's always debate over preventive services. Mammograms are an example. Should you have mammograms under the age of, I can't remember, it's 50 or 55. Used to be common. Now the thought is, well, maybe that's not cost effective. Maybe it's not a good idea. Maybe it doesn't save lives in the long run. Same with PSA. There's a lot of concern about that. Maybe that's something we shouldn't be doing. Because you get a PSA that's bad and you end up having biopsies and things like that, plus the mental distress. So that may not, there are some things like that we're still kind of working out and may change over time as to whether they're covered or not. One of the more controversial aspects, of course, on the preventive services is that it covers contraceptives, and that would include emergency contraceptives as well as sterilization. And this has been a subject of some lawsuits, thinking particularly of the Hobby Lobby case. So this has been something, and it has been polarizing and is contested. Now, what you get when you buy health insurance on the marketplace is you get something, you buy a qualified health plan. Okay? That's what's offered. Now, you can buy it off the exchange too. But if you buy it on the exchange, you might get a subsidy, so it may be worthwhile. Now, exchange is just simply an internet portal, right? I mean, you go online and you browse through the different policies and try to figure out which one best fits you, which one is, you also got to figure premiums differ, right? You get more elaborate coverage, you have to pay more. You have to pay more up front. But these qualified health plans, as noted, provide essential health benefits. And again, this is a small group in individual markets. And they also have limits on cost sharing, like deductibles, co-payments, and other out-of-pockets, maximum amounts. Now, these plans, of course, are supposed to be sold mostly on marketplace exchanges. That's why the marketplace exchanges were set up in each state to facilitate purchase of qualified health plans by individuals and small businesses. So these are private insurances. People say, well, it's socialized medicine. No, it isn't socialized medicine, right? Socialized medicine is something they have in England with the National Health Service when it took over the hospital and employs the doctors and provides the insurance. Canada is a little different. Canada doesn't have socialized medicine either. In Canada, the hospitals aren't owned by the government, or at least some aren't. There are private hospitals. But the government does provide, each province provides a health plan that you can sign up for. Our system, the way this developed, it was developed, the reason this came out of a conservative think tank, right, was that they wanted to preserve private insurance, and this was a way to do it, to set up these marketplace exchanges. In fact, there's a name for that approach. It's called managed competition. The idea is you have markets and you have competition, but you manage it. You have some rules. So that's the template we're talking about here with the marketplace exchanges. You go to the portal, you have choice of plans, but these are plans offered by private insurers. And really the model for it is the Federal Employee Health Benefits Plan, which has been around for quite a while, and if you're a federal employee, you would be familiar with it, because each year you have an annual enrollment period and you have different plans. They give you a certain amount of money to spend, the federal government does if you're an employee, and then you go out and you pick what plan you want. And it's choice of private plans. So that's really the model for this. And again, the attempt was to preserve private insurance. That's what was going on here. Again, when you think about it, that's kind of a conservative idea, right? They also set it up originally, the way Congress set it up, was the states. The idea was the states would set up the exchanges, right? Now this is kind of in a way, a kind of a conservative idea too, right? You're preserving the role and authority of the states, federalism. So it's not the federal government that's going to be doing everything. Each state was supposed to set up their own exchange. But what happened? Well, a lot of states said, we don't want to set up an exchange. And so there was a default provision in the law that said that if the state doesn't set up an exchange, then the federal government will do it. And that happened in most red states. I guess Kentucky, when we think of red states, Kentucky was the exception. They set up their exchange. But now they're about to close it down with their new governor, right? So there's a lot of resistance to this, even though, again, when you think about it, it kind of seems to reinforce federalism. And that way, it's kind of a conservative idea. But there was a lot of opposition. Some was maybe concerned about costs, right, and just that sort of thing, although the federal government did provide grants to study it and to get them started, so that doesn't seem to be the real reason. But that's the way things played out. So many states now have federally facilitated marketplaces. That's what Alabama has. We did not set up a state exchange in Alabama. We looked at it, thought about it, but didn't do it. Okay, so here's a picture of marketplace types, and you can kind of see the federally facilitated marketplaces are in 27 states, coincidentally mostly red states, right? I say coincidentally, perhaps a little bit ironically, but that's the pattern. Now again, Kentucky was kind of the red state that went ahead and set it up and actually was pretty successful, but now they're going to apparently drop it. That's the latest report. The big blue states obviously set up their own exchanges. And some of them were partnerships. Okay? So you had 4 states that got more federal support, and then another 7 states that did kind of a partnership thing with the federal government. But 27 states, the most, had federally facilitated marketplaces. So they passed on setting up a state-based exchange. Only 12 states in D.C. set up a state-based exchange. Now again, these qualified health plans, we talked about the plans for the essential health benefits with, cover preventive services and that have limits on no lifetime limits, annual limits, also have certain requirements on copays, limits on copays and deductibles. These are available in the individual and small group markets on the exchange during annual enrollment periods. So the idea is you've got about 2 or 3 months a year when you have to sign up or renew your coverage. Why have a limited annual enrollment period? What is the reason for that? Well, the reason is we don't want people to be able to wait till they get sick to buy coverage. Okay, so this is a way of encouraging people to go ahead and buy coverage even though right now they aren't sick. If you could buy it at any time, what would the incentives be? Particularly for people that don't think they're going to get sick. You'd have the insurance company on the speed dial, and when you're in the ambulance on the way to the hospital, you'd hit the speed dial, right? Sign up. We don't want people to do that. We need them to participate. They're healthy, right? We want healthy people to buy insurance, so we need them to participate. So that's one reason you have an annual enrollment period. Now, there are qualifying events. So if you lose your insurance because of death of a spouse or something like that, then that's a qualifying event. You can sign up outside the open enrollment period, but it's somewhat limited. Again, as I mentioned earlier, you can purchase qualified health plans outside of the exchanges. You can call Blue Cross and purchase your plan directly from Blue Cross, but we haven't talked about subsidies yet, but if you do that, you don't get a subsidy. So the only way you can get a subsidy is go through the exchange. A little known factor product is temporary insurance coverage. This law does not apply to temporary insurance coverage. So you can go out and you can buy temporary coverage that will cover you for about 11 or 12 months. It'll go from one open enrollment period to the other. And it's quite a bit cheaper than a qualified health plan. Now, they do medical underwriting, right? But if you're a healthy person, you can buy temporary insurance coverage and it's cheaper. Might not be as good a coverage, but that's out there. And I don't know, there's some concern that that might undermine the exchanges. If enough people go out, healthy people go out and buy temporary insurance coverage, then that could undermine or reduce enrollment through the exchanges. So that's out there. Okay, on the exchanges, you've got the metallic plans. Here's what you can buy, and of course each one has a different premium charge. Even though it's the same insurer, it's all, each one of these would have a different premium, and competing insurers may have different premiums for the same metallic plan. But the platinum is obviously that's the best one, right? Best coverage, but it's also going to cost you a good deal more. Gold is at 80% actuarial value, a little less coverage than platinum. When we talk about actuarial value, we're talking about what's your predicted expenditures during the year. Should cover about 90% of its platinum, gold about 80%. Silver, which is the most popular, is, I think it's the most popular. It's the one you can get cost-sharing subsidies with, so I suspect it is. It's 70% actuarial value. And the bronze is 60%. But you're going to get a pretty high deductible with the bronze, right? You're going to have to probably spend a good deal of money before your coverage kicks in. Now, you can get preventive services without satisfying a deductible, but otherwise, it's cheaper. It's cheaper. If you go, on the exchange, bronze plans are cheaper. They are less money, but the coverage is not as generous. There's also something for people under 30. It's a catastrophic coverage plan. Now, you can couple this with a health savings account, which is a health savings account was set up by federal law, and it allows you to put money in a tax-free in an account, and your employer can also put money in the account, and then you own that account. So you can set it up at a bank or some other similar financial service company, and you can put money in there, subject to certain limits, tax-free, and then if you use that money and you can carry it forward from year to year. It's your account, so you've got the money in there. If you don't spend it, you can carry it forward. And as long as you use it for medical expenses, can't use it for over-the-counter drugs now, but if you use it for medical expenses, you can take the money out of there tax-free. Okay, but this is becoming more common in the private sector, but also on the exchanges, you have catastrophic coverage, which is available for persons, and it has obviously kind of high deductible, right? So that's the key. It's for people that under 30 who think they're healthy, right? It's going to be cheaper. It's going to be a cheaper plan. And you could couple it with a health savings account. You don't have to. But it's a cheaper plan because it's got a higher deductible. It does still cover some preventive services. Includes 3 annual primary care visits. And again, it has a lower premium. But its availability is limited. Again, it's available for people under 30 or people with hardship exemptions, financial hardship exemptions. But the key on this is there's no premium or cost-sharing subsidies available. So you may be better off to buy a silver plan and get a subsidy, and we'll talk about subsidies in a minute. But these plans are available, and the idea was this would entice young people to sign up because it's cheaper. It's got lower premiums. And more, if you don't think you're going to get sick, maybe it doesn't bother you the fact that you have a high deductible. Okay, so you got the 4 metallic plans and the catastrophic plan. That's what you can get on the exchange. Let's talk a little bit about Alabama. This is 2015 numbers. This was last year. Had 171,641 consumers selected or were automatically re-enrolled in quality, affordable health insurance coverage. That's the government language, right? To the marketplace as of February 22nd. That was last year. Okay, so the first year of the exchange was 2014. Right? That's when it went into effect. So this was the second year. And that year, nationwide, there are about 11.7 million consumers that selected a plan or were automatically enrolled in marketplace coverage. So this is the second year. So by now, the glitches are pretty much gone. Okay, so things are working pretty good by this point. So that's the numbers we have for 2015, the second year of the exchange. Now in Alabama, 89% of the people who signed up qualified for a tax credit. And again, we'll talk a little bit more about subsidies, I think, later. But if you sign up and you meet certain income requirements, you can get a subsidy. In fact, people up to 400% of federal poverty level can get a subsidy. The subsidies are available for those between 100 and 400% of federal poverty level, but it's on a sliding scale. You get a lot more subsidy if you're down toward 100% than you do if you're up toward 400%. So 89% of the Alabama consumers that signed up in 2015 qualified for a subsidy, and the average tax credit, this is what they call an advance premium tax credit, they give it to you up front, right, was $266 per month. And 70% of the marketplace enrollees obtained coverage for $100 or less after their tax credit. Okay, so that was a lot of people benefited from those, had significantly benefited from those premium subsidies in the form of advanced tax credits, advanced premium tax credit. Now in 2015 in Alabama, and keep in mind, Alabama has the least competitive private insurance market in the United States. Okay. So we start from that base. If you were out in California and you were looking at an exchange, you'd have all sorts of plans to choose from. But we have limited choice here. We are not a competitive private insurance market. In 2015, consumers could choose from 3 issuers in the marketplace, at least in some counties, and that was up from only 2 in 2014. And if you went on the exchange, there were about 17 choices in the county, an average of 17 choices. These were different metallic plans, et cetera, that were being offered. So that was up. There was a little more choice than was available in 2014. Where the average was only 6. Now the big thing about the marketplace exchanges, the big concern is to keep this all going, we have to have sufficient number of younger, healthier people sign up, right? If only relatively older, sicker people sign up, this isn't going to work, okay? Because your risk pool will unravel. Okay, if you only have older, sicker people, then that will cause a spiral. The premiums will go up, and relatively healthier people will drop out of the pool, and pretty soon you'll have no health insurance pool. Okay, so the key is you got to have enough younger, healthier people sign up. Now, in Alabama in 2015, there were 59,980 consumers that signed up that were under the age of 35. That includes people under 18 as well as people from 18 to 24 and 24 to 35, those 3 groups. Okay, and there were 55,839 consumers aged 18 to 34. Okay, so that number doesn't include the under 18. So that was 32%. The number above was 39% of the enrollees. 2016, we're not done yet, but this is a figure. I'm sure there's more than this by now, but this was December 19th, and 169,596 had enrolled, including, of course, most people, most of the exchanges eligible that were auto renewals, automatic renewals, not automobile insurance, automatic renewals, right? So this is, the numbers were, it looked like it was going to be a little higher enrollment than last year. So there were still 6 weeks left at this time, and they were pretty close to the number they had last year. So it looked like it was going to be a better year than it had been. But, I mean, the other side of it is there's still a lot of people who are eligible who aren't signing up. And if you look at nationwide, I don't know if I have the figure in here, we got open enrollment continuing until January 31st. So there's still some time left. If you get your enrollment done by January 15th, your coverage will be effective February 1st. If you do it later, then you got to wait till March 1st. So, but you can still got time to sign up. Now, nationwide, if you look at the numbers, and I can't remember where I got this on a later slide or not, we're up around probably 11, 12 million again, I think, maybe a little higher this year. And, you know, is that good? I don't know. The original CBO prediction or projection for 2016 was around 21 or 22 million. So we're not, you know, it's not a disaster, but it's not as good as was hoped for or initially. Okay. So in that way, it's been a little bit disappointing. Okay, competition in the marketplace. Well, okay, there's a little bit of competition, not much. Okay, 2014, Blue Cross was the only company that wrote in all the counties. Humana wrote in, I think it was Shelby, Jefferson, and Madison County. So really, in most counties, there was no competition at all. In 2015, United said, well, we're going to go into all the counties. So that makes it a little more competitive. But now, of course, you may have read in the news that United's rethinking the whole thing. They may not even sell insurance on the exchange next year anywhere. So, you know, this is kind of it's an odd thing, but when you think about it, the states with competitive markets tend to be the big blue states, right? And they would be the ones best positioned to benefit from competition among private insurers. Right? If you've got a heavily concentrated market like we have in Alabama, I don't know how much we can benefit from competition among insurers. I think that's questionable. In fact, I would dare to say that a single payer plan probably makes more sense for most red states than it does for blue states. That's a little bizarre, but that's probably true. If you've got a state with a lot of rural areas, you're just not going to have that much competition. So we'll see what happens. If United doesn't come back, it's going to be basically Blue Cross and I guess Humana in three counties after 2016. This is some more about that. Blue Cross initially was the only one that offered in all 67 counties, Humana, Jefferson, Shelby, and Madison. In 2016, of course, Blue Cross is continuing on. United is going to do it too, but there's nobody else in the wings. There were some pretty good increases this year on premiums in Alabama. Alabama Blue requested a 27% rate increase for its silver plan, okay, and a 54% increase for its Blue Access Gold plan. Now, if you're getting a subsidy, a lot of that will be covered by the subsidy, but if you're not getting the subsidy, you'll feel the pain at the time. So those prices are going up. Now, Alabama's, as I understand it, a file and use state, okay? So we don't really do rate regulation in Alabama. You have to file your rates, but we don't, the state government here does not say you can't increase it. Okay? So you have to tell people what you're doing, but you don't have to, you're not subject to rate regulation in Alabama. And there's also something in the Affordable Care Act that calls for some scrutiny at the federal level of rate increases. But again, it's not rate regulation. That's not what it is. Now, if you go back to the Clinton health care plan, that's one big difference between it, and I think, and the Affordable Care Act. The Clinton health plan had a nationwide budget cap, which would have required rate regulation. That is not part of the Affordable Care Act. Now, on the platinum tiered plan, whoa, 71% increase in Alabama. That's Blue Cross. 71% increase for platinum tiered plan. Why would it be so much for platinum tiered? Well, just think about it. Who's going to buy a platinum plan, right? Gives you 90% coverage, but the premiums are pretty high. Do you think healthy people or people who think they're healthy are going to buy the platinum plan? No. It's going to be relatively sicker, older people that are going to buy the platinum plan. So that would be what you'd expect to see. You'd expect to see higher premiums on that plan and bigger increases. And over time, again, it may get so expensive that people just say, I can't afford a platinum plan. They just drop out of it completely. The risk pool unravels. Small group plans requested average increase of 14%. Okay, United Health had a 24.5% rate hike for its off-exchange individual plans. Okay, they weren't on the exchanges last year, so this is just off-exchange. So that gives you some idea of what's going on here. You know, the big problem that insurance companies have traditionally with health insurance, two big problems. One is controlling moral hazard, and the other is adverse selection. Okay, moral hazard means if you have insurance, you're a lot more likely to go to the doctor and spend money on health care. And so that's the moral hazard problem. And you could think about it in terms of fire insurance. The moral hazard problem with fire insurance is people who have fire insurance are more likely to burn down their own buildings, right? That's a moral hazard problem. But we have one, and it's more debatable with health insurance, but arguably there's a moral hazard problem there too. Adverse selection means, quite simply, is that if you're sick, you're more interested in buying health insurance than if you're healthy, right? And that's adverse selection. So insurance companies have always had to figure out how to deal with those factors, and they deal with it in a variety of ways. But with moral hazard, they deal with it by having co-pays and deductibles and co-insurance. With adverse selection, traditionally they dealt with it by having medical underwriting or limits on pre-existing condition coverage. Or if it was in a workplace plan, they made you sign up when you first got the job, and then if you didn't sign up right then, you might not be able to sign up for a while. Presumption being you were healthy. What's another way you could deal with adverse selection? This is a little oversimplified, but if you had an insurance company and you put your office where people had to sign up for insurance on the 10th floor of a building without an elevator, that would be another way of dealing with adverse selection. I don't think anybody does that, but you get the idea. Okay, here's a little picture nationwide, so that it varied around the country. This is for the silver plan, second lowest price silver plan. And this, you see the chart, difference between 2015 and 2016. 2015, it looks like, I'm colorblind, but I think that's yellow or gold. And the other one, I think, is blue. But you can see the differences. In Portland, Oregon, for example, you see that there was a significant increase in 2016 over 2015. Similarly, in Albuquerque and Richmond, Virginia, and Burlington, Vermont, a little less so in Maryland. Portland, Maine also, but you see the average there. So it's a pattern that you see around the country. For the most part, premiums going up. Now, New York, it looks like it went down. And I'm not sure why that is. I'm not that familiar with New York law. They may do more scrutiny of rates there. I don't know what they do. Seattle's the interesting one. See, Seattle went down quite a bit. So, but you know, Washington State has a little different tradition in healthcare. The Seattle area is it's very much an HMO town. And they're also doing direct primary care, which is really interesting. You can actually buy a product on the exchange in Washington State where you basically sign up for catastrophic coverage, and you can couple that with direct primary care that's very reasonably priced. So instead of buying insurance to cover all your primary care needs, you sign up with and there's some clinics that do it there. It costs you, I think, about $50 or $100 a month, and you can get all your primary care there, and then just have a catastrophic policy. And that seems to really be working. That's a good product, I think, and that's what they're doing in Seattle. Okay, well, if you have the ability for people to sign up for insurance, kind of regardless of health status, right? You got a little bit of an adverse selection problem. Okay? One way you deal with that is having the limited open enrollment period, where you kind of try to force people to sign up even though they're healthy. The other way that it's being done is you tax or fine people, right, that don't buy insurance. And this has been very controversial. This is the individual mandate, right? And you can see the amount of the tax is going up. So in 2016, you've got $695 per adult, $347 per child, up to $2,085 per household, or the greater of those two, 2.5% of yearly household income. So for some people with a little higher incomes, that could have somewhat of a bite, right? It might provide some additional incentives to buy insurance. You have to, when you file your tax return, you've got also, it's the insurer that actually sends it, but you have to have proof of coverage. If you don't have proof of coverage and you're due a refund, they'll take this fine out of the refund. But the IRS doesn't, usually if you don't pay taxes, the IRS can come out and seize your bank accounts and your house and everything like that. Can't do it with this law. All they can do is take it out of your refund due. So it's their enforcement mechanisms are more limited. So this is the tax, the individual mandate. And the reason you have to have it, of course, is the idea is to force people who are relatively healthy to buy insurance. Don't wait till you get sick. And that's the idea. You have to preserve the risk pools, you have to have healthy people in there. If you don't have healthy people, it's not going to work. And so this has been controversial. It was challenged, right, in the United States Supreme Court. In NFI versus Sebelius in 2012, the United States Supreme Court upheld the mandate. It was a close call. The four Democrat appointees were voted in favor of upholding the mandate under the Commerce Clause. And the federal government's a government of limited powers, so when the federal government does something, they actually have to go to Article 1, Section 8 of the Constitution and see whether there's some power listed in there that they can base their regulation on. And the one that was based on initially here was power to regulate interstate commerce. So the argument was insurance is interstate commerce, so the federal government can impose this penalty. The counter-argument was there was no prior case of a government regulation forcing somebody to buy something being upheld in the Commerce Clause. If you could do that, then the federal government could say, well, car sales are down this year. We think you need to buy a new car. Or we think you need to eat broccoli, so you better buy some broccoli, and you better eat it too, by the way. So could the government do that under the Commerce Clause? Well, the way it played out, you had 4 Republicans who said, actually 5 Republicans who said, appointees who said, no, you can't, the government can't do that under the Commerce Clause. And you had 4 Democrat appointees who said, yes, you can do it under the Commerce Clause. And then you had Chief Justice Roberts, and he said, even if you can't do it under the Commerce Clause, it's a tax, and the federal government has the power to tax and spend. So that's why it was upheld by the U.S. Supreme Court. The other question is, this has been something that's been very polarizing, people very upset about it. But this is an idea that clearly came out of a conservative think tank. This was one of the key parts of the Heritage Foundation plan. And the idea was kind of a conservative idea. It was people need to take personal responsibility. So that's the origins of it. You can debate whether it's a wise thing to do or not. But if you look at the genealogy of it, that's where it came from. And it's not clear that it'll work. I mean, is this enough money to incentivize people? I'm not sure. If the Dutch had adopted a plan very similar to this a couple of years before we adopted it, and their fine was about the same as the insurance premium. Okay, that pretty clearly would get people's attention. I don't know whether this is enough now. The way it started out, it probably wasn't at all, $95 per adult. Okay, now there are exemptions from the individual mandate. If you really can't pay it, they let you off the hook. If you have religious objections, I'm thinking probably Christian Scientists primarily. There are people that have just religious objections to health care. They don't want health care. Member of a healthcare sharing ministry. Now this is an interesting one. Healthcare sharing ministries are growing. These are organizations, and they have to have been in effect or in existence prior to 2010. But what they are, it's a group of people, usually of similar religious persuasion, that get together and agree to share health care expenses. Okay, and it's not considered insurance. But if you're a member of one of these pre-existing health care sharing ministries, you don't have to, you're not subject to the fine. Actually, the charges are pretty reasonable. I guess there's some concern about solvency if they had a really bad year, but because they don't have big reserves, but that's out there. And there's quite a few people signing up for it. Indian tribes. Why not Indian tribes? Well, they have the Indian Health Service, right? So they already have socialized medicine in the tribes. Short coverage gap, less than 3 months. They don't make you do that. If you're an undocumented immigrant, you don't have to sign up. If you're in jail, you don't have to. Okay? Why not? Well, you're in jail, the state has to provide health care for you. That's part of your cruel and unusual punishment if they don't take care of you, your medical problems. Medical care may not be that great, it probably varies, but that you don't have to sign up. Affordability, there is an affordability exemption. If the plan is just too expensive, more than 8% of income. If your income's really low, below the tax filing threshold. And then there's this kind of general hardship exception. Okay, so this is the third leg of the stool. We've gone through two of them. We've gone through insurance reforms, right? And we also talked about marketplace exchanges under that. Then we looked at the individual mandate. So the first leg is we're going to do all these insurance reforms. We're not going to do medical underwriting. And the problem that arises from that is adverse selection. Too many sick people and not enough healthy people sign up. So the next leg of the stool addresses, that's the individual mandate. That is an attempt to address that problem. It's a way to try to get healthy people to sign up by threatening them with a tax or a fine. Okay. And then the third leg is, well, okay, if we're going to force people to buy these insurance policies, that may be really difficult, really a stretch for a lot of people. It may be a big stretch. Because, you look at the average cost. What is the average family plan now? About $17,000 a year. Average individual plan is about $10,000 a year. Okay. That's pretty expensive. So the way to deal with that is we provide subsidies based on income in the form of advanceable premium tax credits. And so here's the sliding scale. And the way this works is your premiums are limited to a percentage of income. So if you're 100 up to 133% of federal poverty level, you're not going to have to pay more than 2% of your income. If you're 103 to 150%, 4%. You can see it goes on. Down at the bottom, 300 to 400%, your cap is 9.5% of income. Now, I think 400% of federal poverty level for a family of four is about $90,000. So you're getting kind of up in the income levels to some extent here. But again, the subsidy is quite a bit lower with your income cap at 9.5% at that level than it is down at the bottom. If you're under 100%, you can't get a subsidy. Subsidies start at 100%. Why is that? Well, the idea was we were going to expand Medicaid. And actually, the Medicaid expansion would cover people up to 138%. So it didn't seem like having subsidies for people under 100% was necessary. However, if you're in a state that didn't expand, you have a peculiar situation. The really poor people can't get the subsidy, and they don't have Medicaid, so they're in the worst shape. Here's the average second lowest cost silver premium for a 40-year-old non-smoker. They can't also rate you on smoking. They can't medically underwrite you, but geography, there's a little variation, age, and smoking. They can give you a higher premium there. So if you look at somebody with $30,000 income, in 2015, for this silver plan, it would be, which is 70% actuarial value, 264 before tax credit, 208 after tax credit. This is for somebody with a single person with $30,000 income. 2016, it'd be actually a couple of dollars less after tax credit, even though the premium went up, $288. It's only $206. Okay. This is reduction in monthly premiums from advanced premium tax credit in Alabama. Just some more details about that. This is from last year. So this was looking at about 142,000 people last year at 1/30/2015, and about 89% of those people got subsidies. Average premium before the subsidy, advanceable premium tax credit, was $360. Average premium after was $268. That was average monthly APTC was $268. Average monthly premium after the tax credit was $92. So pretty substantial reduction, 75% reduction. Cost-sharing subsidies are also available, but only on silver plans. Okay, so silver plans will reduce the reduces the out-of-pocket maximum in silver plans for households with incomes between 100 and 250% of federal poverty level. For the silver plan, if you're in this 100 or 150% federal poverty level, it increases the actuarial value from 70% to 94%. So you would see the benefit of that in terms of reduced deductibles and copays. And then there's a little less up at the top. But it only goes up to 250% of federal poverty level, and it's only when you buy the silver plan. Okay, you can't get this subsidy with other plans. Okay, large employers. Okay, this is a little switch here. We're off the three-legged stool now. Okay, so we got large employers. So beginning in 2016, employers with more than 50 full-time equivalent. That means you count part-timers too to get to that 50, but they're at a reduced, you reduce the part-timers to a percentage. So it's, if you got 50 full-time equivalents, then you're subject as an employer to a shared responsibility payment. If you fail to offer minimum essential coverage to 95% of your full-time equivalents, and one full-time equivalent employee goes to the exchange and gets a subsidy, then you're subject to a fine of $2,000 per full-time employee, excluding the first 30 employees. What's minimum essential coverage? Don't get this confused with qualified health plans. Don't get it confused with essential health benefits. It can be much skimpier. Probably basic hospital care, basic physician services, but not much else. Okay, so minimum essential coverage is not all that comprehensive. If the employer offers minimum essential coverage, whatever that is, and there's some regs that define that in some detail, but the coverage is not affordable or fails to provide minimum value, and one full-time employee receives a subsidy, then the employer is assessed a lesser of $3,000 for each employee receiving a subsidy or $2,000 per full-time employee. And this is really getting down in the weeds, you know, because here, even though essential health benefits, you're not required to include those in the plan. When you're making a determination of whether the plan provides minimum value, the standard they look at is essential health benefits. So this is great. I tell students, you know, if you want to be an employee benefits lawyer, this is good for you, right? This is good work. Less than 58 FTEs, you don't have to provide coverage, but if you purchase coverage for your employees, if you're under 50, you're subject to advanced adjusted community rating, and you have to provide essential health benefits unless you're grandfathered in. The problem with this is this makes it potentially more expensive for smaller employers to provide coverage, right? Because instead of getting, if you've got a healthy group of employees, instead of getting experience rating, now you've got adjusted community rating. And you have to provide the essential health benefits. So this makes, it's increased costs potentially for small employers. So a lot of small employers are now looking at self-insuring because they're not subject then to the essential health benefits and adjusted community rating. Now the federal government is now saying that we consider small groups for rating purposes to include firms with up to 100 FTEs. So the idea is to force firms up to 100 FTEs into the full small group market to strengthen that. But some of these employers don't want to go there. Okay, so they don't want to self-insure. So they've decided to self-insure to avoid that. So you can avoid those requirements, reduce your costs potentially by shifting to self-insurance. Again, fully insured large groups aren't subject to the essential health benefits requirement, but that could change in 2017 if states open up the exchanges to large employer groups. The Cadillac tax, some of you may have heard of that. This is an interesting one because beginning in 2018, if you provide generous health coverage for your employees that exceeds $10,200 for single coverage and $27,500 for family coverage in terms of cost, that means you have to pay, and those costs are calculated by both employer and employee contributions. That means you have to pay a 40% excise tax on anything above that amount. You can't get out of a 40% excise tax. Okay, so if you provided a plan that was worth $14,000, say, you'd pay 40% of $3,800 to the federal government. So the idea is most companies are going to say, well, we don't want to have plans that are go beyond those values. We don't be subject to excise tax. So going forward, there's going to be inflation, right? So a lot of plans are going to bump up against this eventually because the threshold's pegged to the CPI, but health insurance costs have historically increased at rates higher than the CPI. So over time, more and more plans are going to be subject to Cadillac tax, so that will force a reduction in benefits. And that's a deliberate policy. The idea is to put a cap or a limit on the tax subsidy, because that's the thing about private health insurance. That's why we have so much employer-sponsored health insurance, is because there's a tax subsidy. Employees don't have to pay taxes on compensation in the form of health insurance benefits. They have to pay taxes on wages, but not health insurance benefits. So the government's giving what we might call it, sometimes they call it a tax expenditure. Literally billions and billions of dollars a year go to subsidize private health insurance. And the higher income you are, the bigger subsidy you get because you have a higher marginal tax rate. So it's a regressive system. Okay, Medicaid expansion. I'll try to move this pretty quickly. We didn't expand in Alabama. The contemplation in the act was that states, they put a gun to the head of states. They said, if you don't expand Medicaid, you lose all your Medicaid money, all of it. But the Supreme Court said you couldn't do that. That's coercion and commandeering. Okay, so that gave states the option not to expand Medicaid. Here's the increased funding. This is a really good deal for states, it looks like to me. 100% through 2016, drops a little, but even by 2020, the federal government's still funding 90% of it. I mean, Alabama, relatively poorer states get more money for Medicaid than relatively richer states. I think Alabama's already about 72, 73% paid by the federal government, but this takes it up, 100%, and then down to 90. Of course, governors in several states, including Alabama, have rejected Medicaid expansion. And some states, however, have decided they would do it under what they call 1115 waiver. So they have some states that put together their own plans, some of them using exchange-based policies, sometimes even requiring some premium payments by beneficiaries. But you have to go to the federal government to get a 1115 waiver to do this. And there's been, you see, here's the state of Medicaid expansion. Okay? Obviously, I think those are gold and blue again. But those are the states not adopting, quite a few, 19 states, including Alabama. Now you've got 3 states in there where they're discussing it. 31 states have adopted. Okay, Alabama's insured rate did drop some, actually better than other states that didn't expand Medicaid. So there has been some progress after 2014. Here's the uninsured rates for states that expanded Medicaid versus states that did not. And you can see the states in red did not expand Medicaid, and they have an average uninsured rate of 12.74%. States in green expanded Medicaid, and they have an average uninsured rate of 9.35%, so it is lower. Here's the states with the 1115 waivers. Just a smattering of them around. Arkansas being the most notable red state, right? Got an 1115 waiver. Here's from David Becker, right? What happens? Here's some estimates from the Becker-Morrissey study. We project that a coverage expansion would reduce the state's uninsured population by 232,000 while generating $20 billion in new economic activity and a $935 million increase in net state tax revenues. That's pretty significant. And keep in mind that hospitals have gotten the cuts to disproportionate share, right? So this, I'm sure hospitals would welcome this. Medicaid eligibility in Alabama, this just shows you how skimpy it is. Alabama has probably got the skimpiest program around. And you can see, for adults, income has to be below 11%. Medicaid expansion calls for covering everybody, all adults, under 133% federal poverty level, with a 5% disregard, so it actually is up to 138% federal poverty level. So this would be a big shift in Alabama. There'd be a lot of people covered that aren't covered now. Governor Bentley, is he going to do it? I don't know. He teases once in a while. We don't know for sure. Seems to be open to it now, so we'll see what happens. Okay, I'm done. I took up most of the time, but I'm happy to answer any questions.
Do we have any questions that have come in through email?
We haven't had any come in, but I'm certainly ready to supply a whole stable of questions for Dr.
And David asks hard questions.
I'll try to give you some softballs today. So I think, obviously, over the past few years, the ACA has survived several important legal challenges, and I was kind of just curious as to what you thought were some of the biggest hurdles left for the successful implementation of the ACA in terms of its goals of whether it's expanding coverage or controlling healthcare costs.
As far as legal challenges, yes, we did have, the NFIB versus Sebelius that upheld the mandate and also held that Medicaid expansion would be optional in the states. And then there was another case, King versus Burwell, which argued, based on the text, that subsidies would not be available on federally facilitated marketplaces. And indeed, that's what the statute seemed to say, but the Supreme Court decided that there would be subsidies. So that saved the exchanges. That really would have been Armageddon for the exchanges if the court had gone the other way. I think going forward, you know, as I said, it's been a little, the numbers have been a little bit disappointing in terms of the ones that have numbers that have signed up for the exchanges, and the premiums are going up, and so you do have losers under this legislation. And I have a friend here in town who has a large family, and he was paying prior to the ACA about $800 a month for his insurance to cover his family. He didn't have employer-sponsored health insurance. Post-ACA is paying about $2,000 a month. Okay, so there are some losers under this. So that's the way it's set up. There are winners and losers. So that continues some polarization. I mean, looking ahead, we don't know the next election. It's going to be obviously there's some parts of this legislation that are popular and working, and it's going to be very hard for whoever comes in to say, oh yeah, we're going to go back to, say, medical underwriting. Or we're going to kick these kids off that got their parents' insurance. That's going to be tough to do. I don't think that's going to happen. So I'm hoping that sometime people will actually be able to get together and talk in some sensible fashion and figure out what's working and what isn't. I mean, it'd be nice to do some evidence-based policy making going forward. But whether we're capable of that, I don't know.
Yeah, you kind of read my mind with my next question about kind of those losers and the fact that there are these people that don't qualify for subsidies, which I imagine is the case there.
Exactly.
So another thing you brought up was kind of who is enrolling through the marketplaces and the fact that the overwhelming majority of people that are signing up for plans in Alabama are people that are receiving fairly generous subsidies. And I was curious as to kind of what are the consequences of who this mix of enrollees is, and will the problem be solved by getting more young and healthy people into the risk pool?
Well, I suppose the problem would be solved if you had a rush of younger, healthier people signing up. That would at least maintain stable risk pools. I think the problem with the basic design is that you're basically taking money from younger, healthier people and using it to subsidize older, sicker people. Now, I think that's okay, but you know, if you're going to really do that, you probably ought to do it through general tax revenues, not this approach where we're going to charge you. You know, it's like, how much money do you go to the used car lot? How much is the car? Well, how much money do you have? Right?
Yeah, I think it's that issue about like how we finance this bill. We typically think about financing as tax revenues that are raised, but here it's a little bit more complicated.
It is more complicated.
With respect to...
And less transparent.
Yeah, and that's the key to passing major legislation.
Yeah, as has been pointed out by Jonathan Gruber.
Yes, and we're going to do that more eloquently today. So obviously Alabama is one of 27 states that didn't set up its own marketplace and has used the federally facilitated exchange. Do you think that decision affected the enrollment in the state of Alabama or other states that use the federally facilitated exchange, or premium growth over time?
Well, I wonder about that. It's possible if a governor and the state really got on board and said, oh, yeah, we're going to set up the exchange and this is a good thing, you might have seen higher enrollment. But I think that more than anything, it'd be like the political or atmosphere that's generated when you have this vehement opposition. That might depress enrollment, I'm guessing.
Yeah, and it's kind of hard to separate the federal facilitated exchange from the kind of what was the role of the state and the outreach. And
most people don't really get into the weeds like that, and they know. You know, if you got all the leading politicians in the state talking about what a horrible piece of legislation that is, I suspect that might depress.
That doesn't help. So you've talked a lot about the impact of the ACA on coverage in the context of this three-legged stool. What do we know thus far about its impact on the growth of health spending, and what do you see as some of the strengths and weaknesses of the ACA in this effort to control the growth of health spending?
Yeah, health spending went down during the recession. It's on its way back up. I don't recall what it was last year, but it's definitely going back up to. I mean, historically, it's always been at least 2 or 3 points, I think, above the CPI. You'd probably know better than me about that, but So we seem to be heading back to those levels. Now, there are some payment reforms in the ACA that are specific to Medicare, but could have wider influence if Medicare kind of sets the standard. And the idea that there'd be payment for value instead of fee for service. Could that save money if it's done right? I suppose it could. We just don't know yet. Medical homes are another, accountable care organizations. There's one of the things they're using in Medicare where you know, the idea is to allow maybe not capitation, but some sort of different reimbursement, some sort of bundling of payments that might reduce costs, maybe get doctors to work more closely together and coordinate activities. And then you have the medical homes, which are, again, are the idea is to coordinate, do a better job coordinating, particularly care, chronic care. Those might work. We don't know.
Yeah, and I think the fact is that those are tougher problems to take on than simply expanding insurance coverage, and that's why we've heard so much about that.
That's exactly right.
Another thing related to value that you touched on briefly was the Cadillac tax. And if you could elaborate a little bit about kind of what was the motivation behind that, and kind of why are we imposing these very high-seeming taxes on health plans that exceed certain cost thresholds?
Well, it is kind of surprising, but I think you know, policymakers on both sides of the aisle have realized for a long time that the way we do things now with the not taxing medical insurance leads to people over-insuring, having too much insurance, and that's increased prices, reduced price competition in the marketplace for healthcare services. So you've got that problem, and I think the other is just the unfairness of it. Why should the person that's at the 28% or 30% marginal tax rate get a better deal than the people that are down there at the 10% marginal tax rate? That just seems basically unfair.
Yeah, so touching on that issue, do you think that it's odd then that the subsidies for marketplace coverage are actually limited on the basis of income? Because obviously in employer-based context there is no upper limit on my eligibility for a deduction, and in the marketplace there is. And so,
yeah, it does seem kind of inconsistent, doesn't it?
Yeah. So that's,
I mean, one way we could have done this is just instead of doing it through a tax system, just give everybody a voucher. Mm-hmm. And we could even have given bigger vouchers to low-income people than higher-income people. And that would have been, it wouldn't take much bureaucracy to do that, right? Mm-hmm. You could do that, would be a pretty simple scheme. And it'd be fair.
And it's so interesting because as you kind of frame this is largely a Republican kind of driven piece of healthcare legislation. A lot of those ideas about using subsidies rather than deductions, which are inherently regressive, have been brought up by Republicans previously.
That's true. Yeah, Republicans have an interesting record. As you know, remember Richard Nixon really got on board the HMO model early on.
And I think we're out of time.
All right.
And this is Dr. David Becker. I don't think we actually introduced you, but UAB School of Public Health. Thank you, Jack.
You're
That was
welcome.
great, wonderful information, and thank you, David, for your great questions. And we appreciate everybody tuning in today.